Hello, I'm Dr. Richard Hotchkiss at Washington University School of Medicine, an ICU physician. I've done a lot of research in sepsis, and I'm going to talk to you today about immune therapies in sepsis, which we believe are going to be promising for treating patients in the future. So, the prevailing theory of sepsis for many decades, 1970s onwards, was that sepsis was a problem with unbridled inflammation. Lewis Thomas had an article in the New England Journal entitled Germs, in which he postulated and stated that, as you can see in the quotation here, the microorganisms that seem to have it in for us turn out to be rather more like bystanders. It is our response to their presence that makes the disease. Our arsenals for fighting off bacteria are so powerful that we're more in danger from them than the invaders. In other words, it's the body's response that's harming us, not the bacteria. There is an article in Science that termed sepsis an immune system gone haywire. Now, I'm sure you all have seen examples of patients that have these really incredible fevers and shock, and they're just hard to keep them alive that first day or so of sepsis. Group A beta hemolytic strep, the patients with flesh-eating bacteria, toxic shock syndrome, and Neisseria meningitis. These are all examples of these type of patients that can die from the response. So the implication is therapy should be directed at blocking the body's response to these infections. So two discoveries sort of supported this theory. One, in the 1980s, there was this discovery of tumor necrosis factor and interleukin-1. These were pro-inflammatory cytokines that were shown to be massively elevated in certain models of sepsis. If you give, for example, baboons, E. coli bacteria, or endotoxin, the animals have incredibly high levels of tumor necrosis factor, and they can be saved if you give them antibodies that block tumor necrosis factor or interleukin-1. So this seemed to make sense that it's the body's response that is killing us in severe sepsis. So based upon that theory, there were over 100 trials. The pharmaceutical companies tried over 100 trials of drugs that could block inflammation or block cytokines. And none of these were effective in improving survival in sepsis. Furthermore, studies that were done in patients with sepsis showed that, in general, for almost the vast majority of patients, the levels of tumor necrosis factor and interleukin-1 beta were 100-fold lower than that would occur in these animal models of sepsis. So they weren't, the hyperinflammation due to cytokines was just not occurring to that degree. I like this quotation: just because the path is well trodden doesn't mean that you're headed in the right direction. So over time, there have been a number of ways to relook at the problem of sepsis. And the current thinking is that there are both pro-inflammatory responses. You can see here where there's a hyperactivation of the immune system, but also there's an anti-inflammatory response that occurs at the same time. Early on in sepsis, you can have this hyperinflammatory response. This is when the circulating TNF alpha and other cytokines are markedly elevated, and patients can die occasionally in this early phase. However, we've gotten much better at keeping patients alive, and most of them will progress on to an immunosuppressive phase, and this is where the majority of deaths occur. There was a recent paper in Lancet Infectious Disease, December of last year, 2022, and it showed, these are some of the key points in this article that really discuss this evolution in our thinking. That modern intensive care medicine has massively reduced early mortality in patients with sepsis. Most patients do not die during antibiotic therapy and instead die after the assumed to be successful completion of such therapy. Long-term follow-up of patients after severe infection showed substantially higher mortality in the months after infection. So they keep dying. The patients die of secondary infections later. The reason for this increased long-term mortality are poorly understood. Current concepts argue that the cause is relapsing infections and superinfections caused by immunoparalysis. They mean that your immune system is not working well. So a current concept that has evolved is that what we should really do to improve survival in sepsis is to try to target the host immune system and to improve its ability to fight the infection. There's a strong rationale for this. For example, when you look at patients, who's dying of sepsis? It's patients predominantly with weakened immune systems, the elderly patients who have immune senescence, meaning their immune systems don't work well because of age, patients with higher comorbidities, liver disease, kidney disease. Also, boosting immunity may decrease secondary infections and hospital readmissions, which are major causes of morbidity and mortality. 40% of deaths occur after day 30. Furthermore, what's really important is boosting immunity will provide protection against a broad range of opportunistic type pathogens. I'm sure you're reading in the news, it's very prominent, these superbugs that are killing a lot of people, developing in patients in the ICU, multi-drug resistant bacteria and fungi. These are not very virulent bacteria. They target people with weakened immune systems. So if you boost their immune system, you may be able to improve survival. Further evidence, those of you who take care of patients that are septic have noticed that hypothermic septic patients have increased mortality, failure to mount an immune response. This was a study done by Dr. Drury in critical care medicine, and she looked at the survival of 445 patients with bacteremia by temperature. And you can see those that were hypothermic had over a 50% mortality, the blue line, compared to the mortality of those which mounted a febrile response. So our laboratory and colleagues did a study in which we did rapid bedside autopsies in the intensive care unit in patients that died of sepsis and looked at their immune system. What we showed is that when you took out their immune cells from the spleen and stimulated them, they were very poorly functional, and they made less than 10 to 20% of the cytokines that were made from spleen cells from a non-septic patient. Furthermore, we identified T cell exhaustion as a likely mechanism for the immune suppression. Now, in talking again, further evidence for this long-term immune suppression that occurs with sepsis. Here you can see on this far right-hand part of the PowerPoint slide in a red box is the fact that once you are discharged from the ICU, the story is not over. If you look at the data, if you're discharged from the ICU and you look out 90 days, you have a 30% chance of being readmitted to the hospital, usually for another infection. As it says here, primary sepsis readmissions account for more U.S. healthcare expenditures than any other cause. So we like to say, consider sepsis as a race to the death between the pathogens. Here, these are gram-negative rods, and the host immune cells, your lymphocytes, neutrophils, and monocytes. The key question is, how do we re-engage the immune system? Well, this is from immunohistochemical slide of that autopsy study we did. And here you can see in the left-hand part of the panel, these are the slides from non-septic patient spleens stained for CD4 and CD8 T cells. And here's the ones on the right-hand side of the septic patients. You can see how profound the loss is in CD4 T cells, the helper cells, and CD8 T cells. this severely compromises the ability of the patient to survive the infection. Dr. Joe Carcillo at the University of Pittsburgh Medical Center repeated our study in children dying of sepsis and showed that in the spleens from the children that died of non-septic causes, this is a stain for CD4 T cells, there's a very robust number, these purple staining cells, there's very many of them. But in the children that died of sepsis, there's a profound depletion. So sepsis, patients dying of sepsis, both adults and pediatrics, and even there are publications on neonatal sepsis. This is a fairly universal finding of a profound depletion of these lymphocytes. This slide just shows that the cells that are dying in the spleens from these patients have characteristic hallmarks. They're shrunken and fragmented, consistent with apoptotic cells. They're dying by apoptosis. This lymphocyte depletion that occurs in the tissues, if you're one of the classic hallmarks of sepsis, is a low absolute lymphocyte count. Okay, and Dr. Drury in a publication in Shock showed that the more profound the lymphopenia, your low absolute lymphocyte count, I'm sure the physicians get this absolute lymphocyte count usually daily or every few days on their septic patients. And in your CBC, it showed that if the septic patients do not have persistent lymphopenia, their survival is close to 80%. But those with the most severe loss in their absolute lymphocyte counts have close to a 40% survival. So we like to say, this was from a recent paper in the New England Journal, that there really should be a new way of looking at sepsis. So the current paradigm in sepsis is to target the pathogen. This will always be true. You will have different types of pathogens, and you will use antibiotics for bacteria, antivirals for viruses, and antifungals for fungal agents. But in addition, we believe in the future, what you will see, and this is already occurring in the case reports, that you will also have therapies to restore and activate the host immune system. And there are a variety of therapies. We will talk about them really quickly in some case reports and things, and they will be focused on reactivating your immune system. So one of the drugs that we like is interleukin-7. It's been called the maestro of the immune system. So why is IL-7 the maestro of the immune system? Because it increases the number and function of CD4 helper T cells and CD8 T cells. The CD4 T cells are the helper cells because they orchestrate both innate and adaptive immunity. IL-7 has been used in over 500 patients, and there are 3 companies working on this currently in clinical trials, and it's very well tolerated. This is just an example of patients with HIV who had very low circulating lymphocytes, low absolute lymphocyte counts, who were treated with IL-7, study done by Levy and Seretti at NIAID, and showed that this is 3 doses of the IL-7, and there's different concentrations of IL-7. And you can see the patients were very low CD4 and CD8 T cell counts. There was a very nice increase depending upon the dose, and it was an increase that was sustained over many months. So this IL-7 increases your lymphocyte counts. Furthermore, in another study that Dr. Seretti did, patients, as you know, with HIV have loss of their lymphocytes in the gastrointestinal tract. The gastrointestinal tract has the largest number of lymphocytes in the body, and there's evidence that this loss of the lymphocytes in patients with HIV causes leakage of endotoxin from the bowel into the circulation, driving inflammation. This is also true in sepsis, that the gut is the motor of the systemic inflammatory response syndrome. Dr. Seretti and her colleagues did a study in which they treated HIV patients with IL-7. They did biopsies of the colon before and after IL-7 therapy, Here you can see there are very few lymphocytes in the before IL-7 therapy, and then after IL-7 therapy, there's a repopulation, these brown staining cells in the gastrointestinal tract of these patients. Furthermore, in these patients, there was a nice decrease in markers of inflammation, suggesting that the leakage of these endotoxin was improved. Studies by Guillaume Monneray in septic patient blood showed that IL-7 was also able to restore lymphocyte function in these patients. So it brings up the number of lymphocytes in the septic patients and it restores their function. He argued that these results recommend a clinical trial. So IL-7 is also effective in viral and fungal infections. This is just briefly on this. There are many case reports, I included 4 here, in which patients who were dying of JC virus-induced progressive multifocal leukoencephalopathy, PML, were treated on a compassionate basis with IL-7. And you can see from the case reports, the IL-7 was well tolerated, increased their lymphocyte counts, and allowed them to survive the PML. Recently, we were involved in treating a 21-year-old patient who was on a motorcycle going over 100 miles an hour, and he suffered a catastrophic degloving injury of his buttocks and perineum. This patient started to develop, there's a massive wound, gross wound spillage, developed this progressive polymicrobial necrotizing infection of the buttocks and perineum. He remained just with its inability to clear the infection. The wound culture kept growing these fungal pathogens, and they were in blood and tissues, and really it was fairly looking very hopeless. They were taking him to the operating room every other day for debridement. And here you can see this really incredible wounds that he received. If you notice that in the second panel from the left, the green arrows show the margins of the infection that kept progressing every day, every other day of the fungal infection. The top panel shows that the patient had a very low absolute lymphocyte count that we felt was compromised his ability to fight the infection. The patient got the doses of IL-7 as indicated by the syringe, and very rapidly, as indicated by the upper red panel, his absolute lymphocyte increased up to normal. The infection started clearing, and soon, within 5 days after this, his blood cultures and tissue cultures became negative. You can see how clean the wound looked here. Another important mechanism of action of IL-7 is it increases adhesion molecules, which drive it to sites of infection. And here you can see there were very few CD3 T cells on immunohistochemical staining of the wound. Once he began it, you can see how many lymphocytes are present at the wound. And IL-7 also, this is a ELISpot showing each dot as a T cell that's making interferon gamma, how improved the function of the immune cells were. We have also done, there was a multi-center, double-blind, randomized placebo control with IL-7 led by Ed Sherwood at Vanderbilt, Bruno Francois in France, and 27 patients were treated with IL-7, and the therapy was designed to see how it would do, tolerated, and would it improve the absolute lymphocyte counts. It was well tolerated. The only adverse effect was an injection site reaction. It increased lymphocyte proliferation and activation and caused a 2 to 3-fold increase in absolute lymphocyte counts. The red and blue showed the increase in absolute lymphocyte counts that occurred in the patients that were treated with IL-7. There were 2 different dosing regimens versus the placebo. So it was well tolerated and increased their function. So that's interleukin-7. Another very promising immune therapy in sepsis is the checkpoint inhibitors. Okay, so I'm sure you've been bombarded with ads on television for These Opdivo or Keytruda, these are the drugs which are being used predominantly in cancer therapy because of their effects on T cell exhaustion. The Nobel Prize was given to James Allison for the discovery and perfection of these drugs to treat cancer patients. One of the ones that's most prominent being used is this is programmed cell death 1. To give a little background, these, although they're used in cancer, these negative checkpoint inhibitors were first discovered to occur in chronic viral infections, and they're thought to due to chronic inflammation and antigen exposure. If the T cell gets acute antigen exposure, they proliferate and are activated. But if it's chronic, like chronic sepsis or chronic antigen exposure in cancer, the T cells get exhausted. And here they express PD-1. Okay, I'm sure you remember one of the most remarkable stories, a photo of President Jimmy Carter, who was dying of metastatic melanoma to the brain, carries 100% mortality. He was treated with anti-PD-1 antibodies, was completely cured, and is alive today a number of years after this. There are also a number of cases for y'all. If you see these cases, they're not common, but we all see some of them. This was a case where, again, very similar to a motorcycle victim. It was a patient who sustained chest trauma and had this rapidly progressive streptococcal necrotizing fasciitis. You can see the regions that were involved. Despite antibiotics and aggressive surgical debridement, they were failing. It was positive for aspergillus and mucor. The treatment was begun with nivolumab, which is anti-PD-1, and interferon gamma, and the patient resolved and left the hospital. Our group was involved in testing checkpoint inhibitors in sepsis, Bristol Myers Squibb anti-PD L1 antibody. It was done to see, number one, there is concern, would it cause cytokine storm and hyperinflammation? In this study, there were no unexpected safety problems. The causes of death were similar for this, and it was really well tolerated. There was evidence of an increase in monocyte HLA-DR, meaning improved function. So there are studies ongoing now with interferon gamma to treat this, and there's a case series from Didier Payen, and this was a group of 18 adult patients and 2 pediatric patients that were treated. This was just an open label prospective. Interferon gamma was given, and it was well tolerated. Only 3 of the patients died. The other patients had a rapid clinical improvement. They concluded that interferon gamma was well tolerated, improved host immune function, decreased immune suppression, and randomized clinical trials were warranted. There is now a large randomized clinical trial underway with interferon gamma to treat immune suppression and anakinra, anti-interleukin-1, to block the hyperinflammation. Almost through here. Now, I wanted to end up with this interesting trial. So, a study recently published by Ann Drury, in which septic patients who did not mount a good response, febrile response to sepsis, had warming. They were made them warm using warming forced air to increase them. And the goal was to make their temperature 1.5 degrees above their lowest temperature in the previous 24 hours, and mortality was examined in this. There were 56 patients enrolled, again, external warming. Okay, and here's the mortality. Here's the effect of the temperature in the ones that were warmed versus the control group. And you can see that the treated group had a superior survival rate over close to 80%, whereas the controls, it was about 50%. So this is another way that you may be able in the future, these trials will be underway to substantiate that by warming the patient, there's good data you can improve the immune function. So in conclusion, sepsis evolves into an immunosuppressive condition Immunoadjuvant therapy has been life-saving in patients with intractable viral and fungal infections. There's new ways to identify is the patient in the hyper and the hyperinflammatory phase, and that's coming. There's a number of ways. Several immune adjuvants are likely to be successful in sepsis. We like IL-7 because it's so well tolerated and has a broad effect. I would like to thank the sepsis team, the IL-7 trials, Bruno Francois and his team, Ed Sherwood at Vanderbilt, Michelle Moore, and then the anti-PD-1 and PD-L1 trials, Elizabeth Colston and Dennis Grisilla at BMS, academic sites at UPMC, Derek Angus, I think Moldauer, Craig Cooper-Smith, and Elliot Krauser at Ohio State. This is my lab. I'm blessed with a wonderful lab team, many who've been with me for over 20 years. Ken Remy and Monty Mazer worked with me for a number of years. They're now at Case Western, and I think I'll stop there. Thank you very much for your attention to this, and I believe in the future you'll be seeing immune therapies entering the clinical arena. Thank you.